Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Jyoti Malik. Ma'am is MBBS, DGO, DNB, MNAMS, FICS, Medical Superintendent at JJ Institute of Medical Science, Bahadurgarh. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is chronic pelvic pain, a multidisciplinary approach. Now, without any further delay, let me welcome ma'am again at our forum and would like to hand over the session to her. Over to you, ma'am.
Right. Thank you so much. Thank you, Shreyan. Thank you, IJCP. It's always a pleasure to be joining here on this platform. And today, the topic is a little vast. It is multidisciplinary, actually, because we are talking of chronic pelvic pain. And in our OPDs, we get a lot of patients who keep complaining of all this sort of pain, non-specific pain, and we feel they are malingering, and we are not that serious. But sometimes I think when you go through this whole talk, you'll understand that it is something which is very and lasting for more than 6 months. It has no specific etiology. It can be conceptualized as a chronic regional pain syndrome or a functional somatic pain syndrome. So it is typically associated with other functional somatic pain syndromes like irritable bowel syndrome, non-specific chronic fatigue syndrome, bladder pain syndrome, and mental health disorders like post-traumatic stress disorder, depression, etc. So it is not possible to identify sometimes a single etiology or a definitive cause for chronic pelvic pain. And in at least half of the cases, there are associated entities, and sometimes you may see that endometriosis and interstitial cystitis is presenting together. So the prevalence can be 2 to 24%, and it is very common among the reproductive age women, especially around 25 to 30 years. So pathophysiology of this pain could be nociceptive, inflammatory, and neuropathic. So this is something how this the pain, the complete chain reaction occurs. There is a tissue injury. It could be because of trauma, infection, any allergy to the drugs. This leads on to inflammation, release of cytokines, and uroepithelial loss, leading on to spasm in the pelvic floor, the ischemia. This all leads, because of the catecholamines and the neuropathy, again, it leads on to stress, depression, psychological responses, and again into inflammation, again leading again to further pain and further tissue injury. So we have also this gate control theory of pain, where the acute pain is carried by the A fibers, which are large fibers, and the chronic pain is due in the small or the C fibers are responsible. There is a central sensitization. So, regardless of the initial source of pain, there is increasing awareness that persistence of pain from any underlying etiology is a risk factor for development of chronic pain syndrome as a result of the central nervous system changes, which are collectively referred to as central sensitization. So, how do we understand the central sensitization? It is something like when you have an audio speaker control, the output is controlled by a volume knob. Similarly, here also you have the individual genetic makeup coupled with their individual sensory experience, history, influences, which influences their relative pain outset. So, in some women, the pain may not be felt, like example, a labor pain or a pain because of fibroid or endometriosis, while the other person may complain of severe pain. So, we need to have a detailed history, a physical examination, and this can lead us to diagnose the condition which is causing pain. So, we have to have a good history, and this is the pelvic health history form by the International Pelvic Pain Society. So, one can take a detailed history point wise. When did your pain begin? And in your own words, describe your pain. How did your pain begin? Do you recall a specific incidents that occurred when your pain first began? How was how the I mean how in between, how long has been your pain? Whether since the pain, whether the pain is getting better, getting worse, what is the difference? Again, they want you to describe the pain, whether it is always present, often present, or sometimes it is present, or rarely it is present. The type of pain: sharp stabbing, crampy, a heavy feeling in the pelvis, or a dull achy pain, or pulling or tugging pain, throbbing pain, burning pain. So, I mean, depending on the type, how the patient describes their pain, you can sort of start getting the idea whether which organ is responsible for it, and you can start understanding the patient's pain, the cause of root cause of the pain. What makes your pain worse, whether it is walking, whether it is a full bladder, exercise, the bowel movements. So you cannot miss out when you have this chart in front of you, what makes your pain feel better, and then the pain location, the severity scale, the past treatments. We can mark everything on this body map here, and on the private parts, which particular part is, they can localize the pain, gives a very good insight. So depending on the pain history, one can the what is the significance behind it. If it is a crampy pain, could be inflammatory bowel or irritable bowel. If it is an electric shock like pain, there could be a nerve entrapment. If it fluctuates with the menstrual cycles, adenomyosis or endometriosis. If unassociated with cycles, could be adhesions, interstitial cystitis, irritable bowel syndrome, or the musculoskeletal etiologies. Pain with urge to void, interstitial cystitis, urethral syndrome. Postcoital bleeding, think of cervical cancer. Postmenopausal bleeding, think of endometrial cancer. Postmenopausal onset of pain, think of malignancy. Prior abdominal surgery, adhesions could be responsible for it. Unexplained weight loss, again, malignancy or a systemic illness. So all these red flags means that you need to take a immediate attention for this serious systemic disease. Based on the physical examination, what is the significance? What are the based on the findings? Adnexal mass, think of ovarian neoplasm. Enlarged uterus, adenomyosis, chronic tender uterus, chronic endometritis. Lack of uterine mobility on bimanual examination, adhesions or endometriosis. Pain on palpation of outer back or pelvis, could be a abdominal or the pelvic wall could be the source of pain. Pelvic floor muscle tenderness, interstitial cystitis, painful bladder syndrome. Then a point tenderness of the vagina, vulva, or bladder could be due to endometriosis, adhesions, or nerve entrapment. Suburethral mass could be because we can then think of a urethral diverticulum could be the reason. Uterosacral ligament abnormalities, again, endometriosis or malignancy. The vulvar or vestibular pain, vulvodynia. Then the findings, the diagnostic tests. So if there is a gross hematuria, severe interstitial cystitis, or a urinary system malignancy, a mass on sonography can lead point on to a malignancy. So depending on the physical examination, depending on the history, the type of pain, the investigations that we do, we can start getting clue about the cause of the chronic pelvic pain. So, how do we further evaluate and approach? What is the approach to evaluation? Depends on after the history and physical examination and the red flag findings. If they are there, evaluate for serious systemic disease. But if the findings are suggestive of a specific disorder, then you start looking for the cause again. Do the basic test, do the urine analysis, the chlamydia gonorrhea testing, the ultrasonography, and if this is abnormal, again we can start maybe thinking of laparoscopy if all these tests are normal, and gradually evaluate on these lines. So, a differential diagnosis for the chronic pelvic pain, it could be of the following origins. It could be urogynec, could be gastroenterology, neurologic pain, non-genital pain syndrome, musculoskeletal, or psychosocial. So that is why we have to have this multidisciplinary thinking and a multidisciplinary approach where a neurosurgeon, a gynecologist, a gastroenterologist, a neurologist, or a orthopedician, or a psychologist can come out with to help this lady. So after the assessment and the plan, so we do make the initial diagnosis. We check all these for the urogynec conditions, for the gastroenterology, the neurologic, the non-pen. Again, we have these. By following this chart, we can. There is nothing we can miss if we just follow these particular. We go and evaluate the patient on these particular lines. So, coming on to the urogynec, we have so many problems that could be responsible for it, and few of these problems we will understand by certain case-wise presentations that I will take you through in my presentation. So, all these modalities, the ultrasound, transabdominal, transvaginal, the Doppler studies, MRI, these are the various modalities that help us in coming to a particular conclusion and diagnosing. So, if we will now go case wise and discuss some of these problems. So, 32-year-old para 1 delivered 4 year back, complaining of chronic pain, lower abdomen, and dyspareunia for the last 7 to 8 months. Her menstrual cycles are normal, but she has severe dysmenorrhea, and sometimes she has to miss office and resort to injectable analgesics. She has also given us a history of lab endometriotic cystectomy, which was done 5 years back. And on our pelvic examination, on the PSPV examination, we see that the uterus is retroverted, fixed, 10-week size, and there is a nodularity in the posterior fornix. So, just by the history and by the examination, we are sure that what we are dealing with. We might not even go for the blood test, though. On the blood on a CA125, the levels were a little higher. It was 56, and the ultrasound showed adenomyotic uterus with an endometriotic cyst of 4 by 3.3 by 3 centimeter. So the coming on to these are the various laparoscopy findings where how we see endometriosis, the mild endometriotic breaks there, then the endometriosis of appendix, the ovarian endometriosis, the peritoneal endometriosis, endometriosis on the bowel, and this is absolutely a frozen pelvis. How to manage endometriosis? So, the plan of treatment starts with the least invasive approach, and then gradually we go on to the more invasive approaches. And based on the symptoms, the intensity, the stage of disease, what treatment she has taken previously, whether she wants to conceive, whether infertility is her problem. All these are taken into consideration when we plan the treatment. And whatever, regardless of whatever the modality of treatment we undertake, there is a high risk of recurrence in endometriosis. So we can resort, the first line is at basically the non-steroidal anti-inflammatories, and they alleviate the dysmenorrhea. So NSAIDs are the first line, and we use them for their analgesic efficacy. And then if they are not helpful, then the hormonal treatment in the form of progestogens, GnRH agonists, Danazol we are not using these days, combined oral hormonal contraceptives, aromatase inhibitors, which and the antiprogestins can be tried, whatever whichever we feel comfortable with. So, interstitial cystitis, there's a evil twin syndrome where even both of them are together, the interstitial cystitis and endometriosis, they frequently coexist, and a potassium sensitivity test, which is, if it is positive, can make us come to the conclusive diagnosis of interstitial cystitis. So the medical management with the contraceptive pills, they suppress the gonadotrophins, prevent ovulation, cause endometrial atrophy, and can be given for at least a year. GnRH analogs, the duration of use should not be more than 6 months because they cause a decrease in bone marrow density, and they also by they what but their mechanism of action is by producing the hypoestrogenic environment. They give a very good relief, but we cannot use it for long. And also because they decrease the mineral density, one should use some add back therapy in if we are using GnRH analogs. Medroxyprogesterone acetate again inhibits angiogenesis, and it produces effects similar to contraceptive pills, and it also suppresses the gonadotrophins and thins the endometrium. Aromatase inhibitors, what they cause, they prevent the conversion of androgens to estrogen. So when there is less estrogen, these implants do not grow. So endometriosis, the endometriotic implants don't grow. The treatment duration is again 6 months due to their concern with the bone mineral density, and 90% will experience that the pain is relieved, and up to 15 months post treatment they feel relieved. LNG-IUS has again a local effect on the ectopic endometrium by depleting the estrogen and the progesterone receptors, and it may be once put in, it can continue to be there for 5 years. So, if the medical management does not work, then we gradually think of going on to the surgical management. Diagnostic laparoscopy with biopsy of the lesion is the gold standard, and surgical treatment precedes medical treatment in most of the cases. And surgery can be anything: removal of the lesions by electrocautery, by laser, by plasma, or by removing the adhesions, the cyst, and the cyst needs to be excised rather than just aspirating the cyst. It needs a complete excision of the cyst would be the best treatment for endometriotic cysts, and you can use electrocautery or laser vaporization in cases where we get those implants over the peritoneum. The recurrence rate, though, is there depending on how much you have removed And if you've done a very good surgery, the recurrence will not be there. But if you are not able to remove the complete lesion, that there is a 25 to 50% chance of recurrence. So, uterosacral nerve ablation and presacral neurectomy may also be considered to relieve the chronic pelvic pain. Sometimes you combine the two treatments, and once you've given a surgical treatment, then the medical treatment can follow so that the recurrence does not occur. And but if you are thinking of a treatment for infertility, then we do not go in for the medical treatment. Then after the surgical treatment, we give them ovulation induction so that they can conceive. So, coming on to case two now. The second presentation we have is a 34-year-old para 2 comes to OPD with history of lower abdominal pain and excessive greenish white discharge, for which she has taken treatment many times, and now she complains of burning, micturition, and frequent micturition. The examination per speculum show there is an excessive watery, light greenish discharge. Cervix looks normal, but there is cervical and uterine tenderness. And the investigations show elevated DLC, ESR. The cervical smear shows gram negative diplococci. Ultrasound, there is normal uterus, normal adnexal, in the pelvis. So, what is the provisional diagnosis and how we are going to treat her? The diagnosis is PID. PID is a common gynec disease which has many short term and remote complications. Chronic pelvic pain is the long term complication of this PID, and the treatments can be either, if it is not that severe, the PID can be treated as an OPD case, but some cases do require indoor admission. So we give her analgesic, we cover her with broad spectrum antibiotics to cover gonorrhea, the chlamydia trachomatis, and the anaerobes. Review after 48 to 72 hours, particularly those who have a moderate to severe presentation, and they are advised to avoid unprotected intercourse until the patient and her partner have completed the treatment. So the recommended regimes, one can give IM ceftriaxone 250 mg, or another thing we can give cefoxitin 2 gram stat with oral probenecid 1 gram, followed by oral doxycycline 100 mg BD plus metronidazole 400 mg BD for 14 days, or oral fluoxetine 400 BD plus oral metronidazole 400 BD for 14 days. In both the regimes, metronidazole is included so as to cover for the anaerobic bacteria. Oral cefixime as a single dose can be used as an alternative to ceftriaxone. One should avoid ofloxacin in patients who are at high risk of gonococcal PID because of increasing quinolone resistance. An alternative regime can be IM ceftriaxone followed by azithromycin 1 gram per week for 2 weeks. So, when do these patients require admission to the hospital? There, if the patient has a clinically severe disease, she has fever more than 38 degree, or we are suspecting ectopic pregnancy, or there's tuber ovarian abscess, or there are signs of peritonitis, PID in pregnancy. If the patient is pregnant and PID, she needs to be admitted. The lack of response or intolerance to oral therapy. So these are all the indications where she needs to be admitted. And what do we do? What is the treatment we give? We give her IV antibiotics until 24 hours after the clinical improvement, followed by oral antibiotics. The choice of regime is influenced by the sensitivity, and there's no evidence of superiority of one over the other regime. So you can give cefoxitin 2 gram IV 6 hourly, Doxycycline 100 mg orally or IV 12 hourly for 14 days, oral metrogel 400 milligram BD for 14 days. You can also otherwise you choose this clindamycin 900 mg TDS followed by oral clinda 450 mg QID 14 days or oral doxy with metro and clinda with gentamicin initially 2 mg per kg followed by 1.5 mg per kg TDS. Now, if there is a pelvic abscess, we need to drain it. We need to do the laparoscopic division of adhesions and drainage of abscess so that there is an early resolution of the disease. Sometimes a USG guided drainage of pelvic fluid collection may be done, and if there is perihepatitis adhesiolysis, there is no evidence that this is superior to antibiotics. If it is ruptured GO abscess, again, this is one indication where you need to go to drain the abscess and do a the peritoneal wash needs to be given. So, the follow-up, how do we follow up? 4 to 6 weeks. We assess how is the clinical response, with how is their compliance with the antibiotics, and we screen and treat the sexual contacts. So these are the various the Neisseria gonorrhoeae, and how do we diagnose them by and what is the treatment? This is a very concise chart how you can treat the PID by Neisseria, by chlamydia, or by herpes simplex viruses. So the specimen we need to take the vaginal or endocervical swab, do a NAT test, or one can take a urethral swab. And in men, one can take the first pass urine or the urethral swab. Give the treatment is ceftriaxone and azithro. And similarly for chlamydia, NAT, cell culture, ELISA, these are the various tests. And one can take the swab or the first catch urine specimen. Again, in the men, urine or a urethral swab, or one can even take rectal, pharyngeal, or the conjunctival swabs in cases of chlamydia. Herpes, they present with these ulcers, genital ulcers, or the oral ulcers, and the treatment is acyclovir, valcyclovir, and famciclovir. Coming on to the third case, Mrs. R, 27-year-old, comes in requesting treatment for pelvic pain, urinary frequency, and for these symptoms, she is suffering for about 6 months. She also describes a feeling of pressure over the suprapubic area, which is relieved by voiding. There is sensitivity over vulval area, and both daytime frequency and nocturia. Patient also gives history of allergy and chronic fatigue syndrome of 2 years duration. So when you inquire about her prior medical history, her report suggests that she had frequent urine tract infections during adolescence. So we order a urine analysis, a culture, both are negative. So urine culture is negative. So now how do we approach her? So, our diagnosis is suspected interstitial cystitis in this patient who has suprapubic pain or the suprapubic pressure, discomfort, and frequency of urination for more than 3 months in the absence of a urinary tract infection or other pelvic condition with similar symptoms. So the medical workup, you do a full gynec evaluation, you do the basic test, CBC, ESR, the liver function, thyroid, you do the general workup, the urine culture, sensitivity and all, and that was already sterile. Further evaluation needs to be done by a digital and manometric pelvic floor muscle examination, the Kaufman Q-tip test, touch sensitivity test, potassium sensitivity test, and cystoscopy after hydrodistension. So, on cystoscopy after hydrodistension, One sees these submucosal hemorrhages, or one can even see these glomerulations. And the glomerulations can occur also in other bladder conditions, but these are not diagnostic as of, but these findings confirm, along with the hemorrhages, confirm the diagnosis of IC. So, how would you treat these patients? The treatment of IC or is multimodal. One needs to avoid the dietary irritants. So one has a whole list where the spicy things, the coffee, and one has one. There is on the side also we have the various dietary irritants that can cause ICR there, and one should the patient should be told in detail about avoiding these dietary irritants. One should do a bladder training with urge suppression, and a cognitive behavioral therapy is needed for them. The dietary aid for bladder discomfort, one can give calcium, glycerophosphates, the nutraceuticals, phenazopyridines. Increase the fluid intake so as to minimize the urine getting concentrated. Manual physical therapy for pelvic floor tenderness to relieve the tender muscle points, the contracture lengthening or the scars, and meditation or imagery techniques for pain management, neuromodulation, which can help the urinary frequency or urgency, pelvic floor muscle relaxation training, stress management, transcutaneous electric nerve stimulation, use of elimination diets to help determine which additional specific foods should be avoided, use of heat or cold to the bladder, avoidance of behaviors and activities that are known to exacerbate the bladder irritability, like your pelvic floor muscle strengthening exercises or prolonged constipation or even sexual intercourse. Coming on to the next case, this is 35-year-old woman with menorrhagia, severe dysmenorrhea. A lab-assisted vaginal hysterectomy was done 20 months prior to due to persistent symptoms which had confirmed uterine adenomyosis. Both the ovaries appeared normal during the operation, and she subsequently presented to the OPD due to the left lower abdominal pain for 4 months. So, on the abdominal CT, there is a 3.8 centimeter cystic mass with debris deposition over the right hemipelvis, and an ovarian cyst was suspected. And on a transvaginal ultrasound, again, there was a homogeneous hypoechoic 2.5 by 1.6 centimeter cyst in the right adnexa without the blood flow. And after 2 months of treatment, again, her abdominal pain was still persistent. So, how do you manage this? So, this is a case of residual ovarian syndrome and her abdominal pain. And since the cyst has been persisting, so how do we manage this? So, a laparoscopy was performed, the cyst was found, cystectomy was done, a left salpingo-oophorectomy was performed due to pelvic pain in left adnexa, and histology confirmed the cystic follicle. The patient made an uneventful recovery and she was well 12 months later. Coming on to these ovarian masses and the chronic pelvic pain. So, usually benign ovarian tumors, normally they cause no pain, but sometimes if they are bigger in size, a dull aching pain maybe or a heaviness the patient may complain of, and a big tumor though may cause a abdominal discomfort or a difficulty in walking. A rapid increase in size, a hemorrhage, infection, torsion, or degeneration may cause pain, and infection in the torsion of the pedicle, even in dermoid cyst, may cause pain, fever, vomiting. Patient may be in shock. So whenever patient comes with severe pain or she has fever, vomiting, think of infection, think of also a torsion. 40 to 70% patients with malignant ovarian tumors may complain, they will not complain of severe pain, they'll just complain of vague pain abdomen with altered bowel habits. So think that of that in mind if your patient is an elderly patient and has all these complaining of the vague pain. Do a ultrasound and look out for a malignancy. Now, if it is a simple unilocular cyst, which is less than 7 centimeter, it is usually a functional cyst. Just keep it under observation for 4 to 6 months. You may add OC pills, repeat a ultrasound, and if shows a persistent cyst, patient complains of pain, the size is not decreasing, then you might go in for a laparoscopic excision. Now, in menopausal, the cyst, if it is more than 5 centimeters, should be observed with the ultrasound and a CA125 every 3 months. So, surgical management involves laparoscopic cystectomy, or if it is a perimenopausal patient, one can do a hysterectomy with bilateral salpingo oophorectomy. And if it is malignant mass, then you deal with it accordingly. Case 5, a 30-year-old gravida 2, para 2, having a chronic pelvic pain for 17 years. She is amenorrheic with continuous OCP treatment and she had some improvement with pelvic physiotherapy. Now, patient reports that she has daily pain with intermittent pain flares. She is exhausted, she has a poor sleep quality, and all this she is attributing to the pain. So she is diagnosed with interstitial cystitis, the irritable bowel syndrome, and the temporomandibular joint disorder. The physical examination reveals that the patient has diffused but mild pain in the pelvic floor and the abdominal wall muscles. So, what can we offer her? We can, for the managing the sleep, managing the pain and the depression, one can put her on antidepressants, the amitriptyline. One can put her on cyclobenzaprine, which though it has not been studied in patients with CPP, in fibromyalgia, it causes significant improvement in the pain, sleep, and fatigue and tenderness. And starting it with low dose at the bedtime. The calcium channel blockers, the gabapentin and the pregabalin are the calcium channel blockers which can be used in these cases. So, next case is a case again of a chronic pelvic pain, 38-year-old having a persistent left lower quadrant pain following cesarean delivery. And she had a hysterectomy 2 years ago for this chronic pelvic pain, after which her pain worsened. And she describes daily pain with intermittent flares. So, what is her on examination? She has a focal left lower quadrant pain, and consider the focal pain requires a precisely targeted treatment. You consider the presence of trigger points and peripheral neuropathy in patients with focal abdominal pain. The trigger points are focal, palpable nodules within muscles, and they are markedly painful to palpation and associated with referred pain, motor dysfunction, and occasionally autonomic symptoms. Treatment options, one can give anesthetics like lidocaine, bupivacaine, which act as sodium channel blockers. These can be injected into this area and improvement of often outlasts the anesthetic duration action. Now, this patient, the 47-year-old para 4, complaining of constant dragging pain. Her periods are more or less regular, normal flow. She has a fibroid, a big fibroid, 10 centimeter by 7 by 7.5 centimeter in the posterior wall, intramural, partly subserosal, impacted in the pouch of Douglas. So, how do we manage this? The pelvic masses are another cause of a chronic pelvic pain. The submucosal fibroids cause a colicky pain, the interstitial cause dysmenorrhea, and the subserosal cause a dull ache. And sometimes acute pain can be due to the degeneration in the fibroid. Management depends on the age, parity, symptoms, the fertility desire, the location of the fibroid, and the size. Medical management is the first line. If they are small, one can do medical management prior to surgery to reduce bleeding, correct anemia, reduce the medical management will help reduce the fibroid volume and but this includes tranexamic acid, the NSAIDs, the COCs, the GnRH agonists with add-back therapy, LNG-IUS, sperms, the uliprestol acetate 5 mg daily, or the antiprogestins mifepristone 5 to 25, so 5 mg or 10 mg or even 25 mg daily. Now, surgically, one can go in for either a myomectomy, which can be a hysteroscopic or a laparoscopic myomectomy, or if the family is completed and the patient does not want all these, she can go in for hysterectomy. The newer modalities include UAE, the uterine artery embolization, and the HIFO. 54-year P4 para 4 complaining of something coming out per vagina for last 3 years, has low backache, frequent micturition, cystocele 1 plus, rectocele plus. There is a second degree uterine descent. So the genital prolapse is something which can again lead on to the chronic pelvic pain. So pelvic organ prolapse can produce varying degree of discomfort, leg fatigue, low back pain, a feeling of pelvic pressure or bearing down, and the laxity in the ligaments or the vaginal membrane due to the damaged connective tissue may prevent the normal opening and closure mechanism of the urethra and anus, because muscles need finite lengths to contract properly, and hypermobility of the apex can irritate the pelvic plexus, causing chronic pelvic pain. So treatment can be anything from conservative to surgical. Many women suffer from PMS and vulvodynia, and also they complain of the lower abdominal pain. So PMS, one use SSRIs, fluoxetine or paroxetine. To minimize the side effects, they can be given cyclically 14 days before the periods. Oral contraceptive pills containing drospirenone, GnRH analogs can be given 6 months, for 6 months with ADPAC, or if very severe, one can go in for hysterectomy. Vulval pain and vulvodynamia, a multidisciplinary approach, proper vulval care, counseling, the use of 2% or 5% xylocaine overnight and before intercourse in cases of provoked vulvodynia. The tricyclic antidepressants like amitriptyline, gabapentin, they can be used in increasing doses. The pelvic muscle floor therapy and the surgical treatment in patients not responding to these, where one can do a modified vestibulolectomy. Menopause again comes with more than mood swings, and it deserves its place among chronic pelvic pain conditions. And there is association of CPP and GSM, and GSM is there is a menopause had twice as high odds of having a chronic pain syndrome and twice high odds of having multiple pain diagnosis even after adjusting for all this age, race, BMI. So this in the GSM patients, one can the fibromyalgia, the temporomandibular disorder, low back pain, migraine, anxiety, depression, all these are common. And the clinicians focus on vaginal atrophy and they forget the other things in the pelvis that can cause pain, from bladder pain syndrome to the myofascial pelvic pain to neuralgia to irritable bowel syndromes. So for evaluation, one need to think out of our comfort zone, and one should also include a biopsychosocial evaluation. So a multimodal treatment is needed, and one can use vaginal estrogen, a lidocaine ointment with perhaps uh, physiotherapy, pelvic floor therapy, and sleep, mood, and fatigue disorders should be taken care of. Sometimes the patient assumes that insomnia or mood changes are the symptoms of menopause, but they should be screened for a true sleep or mood disorder on the top of the menopause. Then another case, 54-year-old police constable weighing for 84 kgs, complaining of pain lower abdomen, back, and legs, and more so in the evening because she has to be on duty standing the whole day. So BP is 140/90. The PS shows increased vaginal discharge, cervix congested, and there are increased varicosities on the vulva and posterior aspect of both the thighs. So was the provisional diagnosis is pelvic congestion syndrome, and many times these women have pelvic veins varicosity, and this pelvic congestion syndrome can lead on to chronic pelvic pain syndrome, and they need referral to a vascular surgeon for therapy. So, the spectrum of these pelvic vein disorders, you can have chronic pelvic pain, the pelvic varices, perineal, vulvar, gluteal, renal symptoms, the flank pain, hematuria, the leg symptoms, the pain, swelling, varices, and these are because of two types of pathology, which could be the reflux in these ovarian vein, internal iliac reflux, or it could be due to obstruction of the iliac vein or the renal vein compression, and uh, one needs to take care of that. The UTI, the dysuria, urinary urgency, frequency, a sensation of bladder fullness, or a lower abdominal pain, suprapubic tenderness. So, one of the differential diagnoses in these cases is that of recurrent urinary tract infections. Appropriate antibiotics needs to be given. Complete resolution of symptoms may require approximately a week or so, and the features that have been associated with a more prolonged course include a history of somatization, previous cystitis, urinary frequency, tubercular infection, chronic abdominal pain, palpable lump, and other non-specific manifestations make an early diagnosis difficult, added the difficulty in obtaining the history. Urinary incontinence, the muscular problems in the pelvic floor, the symptoms of pelvic pain, frequency, urgency, painful intercourse, sensation of pelvic pressure, painful defecation, tailbone pain, low back pain can all occur when the muscles of the pelvic floor are too tight. So, weakness in these muscles can contribute to the urinary or bowel incontinence or bladder or rectal prolapse and low back pain. So, physiotherapy, the pelvic physiotherapy after a proper evaluation should be the first line. The
Ma'am, am I audible to you? Hello, ma'am. Am I audible?
contractility of the pelvic floor muscles. So, one should be doing the right
Ma'am,
exercise.
sorry to interrupt. Your video got paused for a minute. So, can you please repeat from that part?
Pardon?
Ma'am, I was saying your video got
Hello?
paused. Hello, am I audible to you, ma'am?
Okay.
Yeah, yeah.
Now can you see it?
Yes, yes. Now we can see, ma'am. Please continue.
Hello?
Hello? Yes, ma'am. You can continue from this part.
Hello, Sion?
Yes, ma'am. Am I audible, ma'am?
Yeah, I'm just concluding. I'm on the two last two slides. Can you see
Yes,
it?
yes. Yes, now I we
Okay.
can see it, ma'am. Please continue.
All right. Okay. Okay. So just to conclude, chronic pelvic pain is defined as a persistent, non-cyclic pain perceived to be in the structures related to pelvis and lasting more than 6 months. Often, no specific etiology can be identified, and it can be conceptualized as a chronic regional pain syndrome or a functional somatic pain syndrome. And it is typically associated with other functional somatic pain syndromes like irritable bowel syndrome, non specific chronic fatigue syndrome, and mental health disorders like post traumatic stress disorder, depression, and diagnosis is often based on the findings from the history, physical examination, a pelvic ultrasound to rule out anatomic abnormalities, a referral for diagnostic evaluation by laparoscopy can be done in severe cases. A curative treatment is elusive. Evidence based therapies are limited. Patients should be evaluated and recommended with treatment of any identifiable disease process like endometriosis, interstitial cystitis, painful bowel syndrome, and comorbid depression. Behavioral therapy should be an integral part of the treatment. In selected cases, neuromodulation of the sacral nerves may be appropriate. Hysterectomy may be considered the last resort if the cause is unknown at origin. Although significant improvements occurs in only about half of the cases, and it should be managed with a collaborative, patient-centered approach. These are the references from where this presentation has been made, and I thank you all for your patient hearing.
Thank you so much, ma'am. We do have some question if you like to take that up.
Yeah,
Hello?
Sion,
Yes, ma'am.
I
Am
think
I audible?
now, yes, yes.
Yeah. So, ma'am, we do have some question which I wanted to ask you. So, ma'am, the first question is when should a patient with CPP be referred to a pain management specialist or psychiatrist?
I did not, your voice is breaking. Can you repeat the question?
Sure, ma'am. The question is when should a patient with CPP be referred to a pain management specialist or psychiatrist?
Yeah, see, once we have we have to rule out the organic cause. I mean, what, see, we saw that it could be a urogenic problem, a gastroenterologist, a muscular problem. So, all these, once you've ruled out that there is, you have ruled out from your own side that there is nothing related to your, to the pelvic organs or to the urogenital part, then I think comes the role of the pain management specialist. When all your
Thank you, ma'am.
medicines have failed, when you have nothing, then you can send her.
Thank you. Next up, ma'am, what are the limitations of surgical intervention in chronic pelvic pain syndrome?
Repeat again.
Sure. The question was, what are the limitations of surgical intervention in chronic pelvic pain syndromes?
Limitations of surgery are that sometimes, like in my last slide, I have written that even if you do hysterectomy, sometimes if the patient has pain related to muscular pain or musculoskeletal pain, then in those particular cases, the surgery may not help. Even if you have done a hysterectomy, it may not help her out. Though psychologically, if she is correlating that this pain is due to her uterus or some uterine infections or a chronic PID sort of a thing or a mild uterine prolapse, if those are the conditions which could be causing her pain, if you have treated those conditions, or if you've ruled out those conditions, or if you've done appropriate surgery accordingly, and if then still if you have not gone to the right diagnosis, the surgery also may not help her.
Ma'am, one last question. How should chronic pelvic pain be approached when it overlap with condition like IBS?
Yeah, so we have to treat the IBS. So that is where the gastroenterologist, the role of a gynec giving, doing the treatment, tackling this problem with the gastroenterologist. So, I mean, then the patient has to go to a gastroentero so as to treat her. I mean, then the irritable bowel syndrome will be treated by them.
Thank you so much, ma'am, for answering all our questions. That's all from our audience. Before concluding, ma'am, any take home message?
Yeah, take home. I think it is a very common entity. The take home is that we cannot, once the patient complains of pain, she has a pain somewhere, though we may not be able to diagnose it. Because we are not able to diagnose does not mean she does not have anything. Because we, in our busy OPD practice, the patient comes, you write her some antibiotics, you write her some analgesics, and you send her again, she comes back. But if you're not able to rightly get her problem sorted, she'll keep on coming, and then after one or two visits, you also feel that you're not able to help her, or maybe you feel she's malingering. And but I think we should take the patient seriously, and we should try and find out. So it is not just the gynec part that one should just keep a focus on that, because that is why we today took this as a modality, multidisciplinary approach. So if you involve the orthopedician along with this, as if you're dealing with a high risk pregnancy, you normally involve other physicians and a pediatrician. Similarly, in a chronic pelvic pain, you involve your other colleagues. You involve your orthopedic friend, the neurologist, and the gastroenterologist, the urosurgeon. So all these, we have to. If we are not able to find, does not mean she doesn't have it. She has a problem. The only thing is we are failing to find it out. So we should think more seriously, and I think that is something. And because we are not able to help these patients gradually, this becomes like a chronic thing to them, and it affects their day to day life. It affects their also the thought process, brings them into depression because they feel they are not being treated, and their whole of the time their mind and focus is on the pain, and their efficiency or their effective the hours of their effective hours of their or the useful time of their life is lost. So we should take them very seriously.
Thank you so much, ma'am, for this wonderful presentation and for this wonderful session. It's a pleasure to have you here with us. Thank you so much.